Hello everybody. Today's topic is brain death and the management of the organ donor. Potential brain death donor. Potential organ donor is defined by the presence of either brainstem death or catastrophic or irreversible brain injury that leads to the fulfilling brainstem death criteria. Now, what is the brainstem death? Brainstem death means the stage at which all brain functions are permanently and irreversibly ceased. Care of potential organ donor. Organ donation system requires the early identification of the potential brain dead donor, early appropriate evaluation, and the conversion of the potential brain dead donor to actual donors. Up to 20% of organ and large number of potential brain dead donors are lost because of the clinical management. Uh, because the clinical management is challenging. This can be overcome with the use of bedside checklists to achieve the cardiovascular, respiratory, and endocrine metabolic targeted physiology. Adequate time should be given for organ optimization and to come out of organ autonomic storm injury. Median time of around 48 hours from autonomic storm to cardiac function recovery has been proven by serial echocardiographic test. So the organ procurement should be done within 30 hours after brainstem death. This prevents the loss of potential donor organs secondary to cardiac arrest. A protocolized and the multi-system ABC approach for organ donation is being recommended. Aim should not be only to increase number of donated organ, but also to increase their quality and reduce the cardiac arrest in potential brain dead donor. This will also preserve the long-term graft function. A simple method to maintain the potential donor is rule of 100. Now, this is the ABC approach and care of organ donor in brain death. Now, what is the ABC care for the organ donor? A is the etiology of the brainstem death and the irreversible coma. B is the brain death alert sign. C is the contraindication to the organ donation. And the rule of 100 is we should maintain the systolic arterial blood pressure more than 100 mmHg, urine output more than 100 ml per hour, PaO2 more than 100 mmHg, hemoglobin concentration more than 10, blood sugar 100 mg per day. Now, what is the pathophysiology behind it? Severe trauma or stroke causes damage to the neuronal tissue. This may lead to the edema, increase in intracranial pressure, and thereby compromising cerebral perfusion. A vicious cycle is initiated in which decreasing cerebral perfusion and increasing ICP interact with each other until no further blood flows in the cranial cavity and transtemporal and transforaminal herniation occurs. This causes damage to the brainstem. Transtentorial herniation causes damage to the brainstem in the rostral to caudal pathway. First, pons is damaged and then medulla. Initial response is hypertension and then bradycardia. This phase of the brain death process, called as Cushing's reflex, as brainstem become ischemic, the vagal cardiomotor nucleus become ischemic, causing the unopposed sympathetic stimulation. Then this leads to tachycardia, hypertension, and high blood levels of the catecholamine. That is autonomic storm, catecholamine surge. This sympathetic surge is an adaptive response to maintain cerebral perfusion pressure. But this surge causes ischemic insult to other organs like kidney, liver, and heart. This phase is followed by the profound reduction in sympathetic outflow with loss of autonomic tone, resulting in vasodilatation and hypotension. The concurrent ischemic damage to hypothalamus and pituitary results in temperature and endocrine dysfunction. Thus, there is interruption in hypothalamic, pituitary, and the adrenocortical regulation. During this period, circulation must be supported and respiration is artificially maintained, and the normal physiological sequelae of the brain death should be anticipated and corrected. Now, what are the laboratory workup that we should should be done. That is blood grouping and typing, complete hemogram, blood glucose, urine analysis, blood urea nitrogen, serum creatinine, serum electrolyte, liver function test, coagulation profile should be assessed. Serological testing for HIV, HSV antibody, HPV surface antigen, core antibody, surface antibody, HCV antibody, IgM, IgG for cytomegalovirus are necessary. Then arterial blood gas, lactate, electrolyte, blood sugar levels need to be monitored every 2 to 4 hourly. Then infection screening, blood culture, endotracheal tube secretion, urine culture must be required if there is evidence of infection or if patient is hospitalized for more than 72 hours. Additional tests may be required for the multi-organ donor, for example, echocardiography for heart and bronchoscopy for lung transplantation. Then what are the physiological and metabolic changes in brain death patient? Cardiovascular system, hemodynamic instability and cardiac function are always encountered in patient after brain death. The sympathetic storm results into the hypertension, tachycardia and arrhythmia. Though usually of short duration, it may lead to cardiac dysfunction, cardiac ischemia, myocardial and the conduction system necrosis. Further, spinal cord ischemia is followed by deactivation of sympathetic storm and loss of cardiac stimulation. This leads to vasodilatation and cardiac dysfunction, clinically presenting as hemodynamic instability in potential donor. Now, what are the other causes of hypertension? Use of diuretics, osmotic diuresis due to hyperglycemia, diabetes insipidus, hypothermic and cold diuresis, inadequate and fluid resuscitation, decreased oncotic pressure after crystalloid resuscitation, ongoing blood loss, rewarming of the patient, relative adrenal insufficiency as a result of trauma, critical illness, can all aggravate hypotension and impair perfusion. Third, circulatory shock as a consequences of impairment of at least one of the three determinant of cardiac output, like preload, contractility, and afterload. Hemodynamic management goals for the management of the hemodynamic status of the donor are as follow: to maintain normovolemia, euvolemia, optimize cardiac output so as to maintain perfusion pressure of all organ with minimal vasoactive support. Hypertension, it occurs due to transient nature of autonomic storm. This causes hypertension, tachycardia, and thereby increase into the myocardial oxygen consumption. Antihypertensives are usually not required. So if needed, short-acting antihypertensives such as esmolol, sodium nitroprusside, hydrolazine, labetalol, and nitroglycerin should be used. Hypotension, the decision for selection of particular fluid depends upon the serum electrolyte, glycemic control, hemodynamic status of the patient, estimated volume deficiency, presence of polyuria from diabetes insipidus. Three strategies are suggested, that is volume expansion, vasopressor, inotropes, and harmonic. For volume expansion, preferred fluid for resuscitation. Initial goal for fluid therapy in the post-brain dead donor is the intravascular volume replacement. So the first choice is isotonic crystalloid. Initially 0.9% normal saline and the ringer lactates are preferred, but later on, depending on hypochloremic metabolic acidosis and hyponatremia, fluid choice changes to the half normal saline or 5% dextrose. Colloidal mostly used as the bolus infusion to tackle rapidly developing hypotension. 5% albumin and the hydroxyethyl starch are available. Hydroxyethyl starch is associated with the acute kidney injury, coagulopathy, and trapping of reticuloendothelial system. PRBC should be transfused to achieve the hematocrit of 30% to maintain oxygen delivery. Liberal fluid balance or hydration with optimal mechanical ventilator setting are considered to be helpful for kidney procurement, uh, but this might be hazardous for the lung procurement. Technique that may be used to assess the effective fluid administration is we should maintain the map of at least 60 mmHg. We should perform the bedside echocardiography. Urine output should be maintained between 1 to 3 ml per kg per hour. We should rule out diabetes insipidus and diuretics. Di- uh, then we should decrease the dose of vasopressors. Other parameters like pulse pressure variation, then cardiac index should be more than 2.5. Central venous oxygen saturation should be more than 70%. Can be used to assess the effectiveness of fluid administration. Now, the vasopressor of choice, vasopressin in pressor dose stabilizes the vasodilatory shock caused by brainstem death. The vasopressin up to 2.4 units per hour may reduce the requirement of other vasoactive agents. The use of low-dose vasopressin counteracts the diabetes insipidus and aids the restoration of the vascular tone by stimulation of the VAV1A receptor and reduces the epinephrine requirement dose. Hence, the selected as the first and second line vasopressor in the management of the brain dead patient. Canadian guideline recommended vasopressin as the first choice vasopressor for donor resuscitation. Norepinephrine is also commonly used for this purpose. It has a potent alpha receptor agonist activity as compared to dopamine. This predisposes to the increased pulmonary capillary permeability, increasing extravascular lung water, coronary and mesenteric vasoconstriction, increasing afterload of the left heart. Dopamine protects against the ischemia and deperfusion injury and inflammation caused by the induction of enzyme heme oxygenase. It was observed that the dopamine helps in the faster alveolar fluid clearance and reduces the dialysis need in post-kidney transplant recipient. But chances of arrhythmia increases with the higher dose of dopamine. Dobutamine epinephrine may be used in the primary cardiac dysfunction. Now, the monitoring tool. Monitoring tools are based on the assessment of the global tissue oxygen supply demand marker. Devices such as central venous catheter, pulmonary artery catheter, and arterial line are recommended. This device provides hemodynamic parameters such as central venous pressure, pulmonary artery occlusion pressure, MAP, cardiac output, and cardiac index. Other devices can be used to calculate cardiac output, stroke volume variation, cardiac index, mixed venous saturation may be valuable for guiding fluid management. For fluid resuscitation, arterial pulse pressure variation, stroke volume variation, variability of the diameter of vena cava, respiratory occlusion test, passive leg raising test, thoracic echocardiography to calculate velocity time integral in left ventricular outflow tract can be used. Most monitoring bedside non-invasive test is transthoracic echocardiography. This device will guide us for the fluid resuscitation, fluid overload, cardiac contractility, and ejection fraction. TTE will also help to assess the condition of myocardium, valves, pericardium for cardiac transplantation consideration. Echocardiography need to be repeated every 2 to 12 hours following aggressive donor management or once vasopressor doses are reduced to minimum. When transthoracic echocardiography cannot be done due to chest wall abnormalities or if cardiac function need to be assessed more accurately than esophageal echocardiography should be considered. Endocrine function. The hypothalamus pituitary axis gets affected in the brainstem death patient. Reduction in the vasopressin level leads to diabetes insipidus. Anterior pituitary hormone deficit results in hypothyroidism and hypocortisolism. Diabetes insipidus results from the deficiency of antidiuretic hormone due to loss of posterior pituitary function. Diabetes insipidus is associated with polyuria leading to hypovolemia, hyperosmolarity, and hypernatremia. Hypernatremia may adversely affect the outcome for renal and liver transplant. Early use of antidiuretic agent in suspected diabetes insipidus may prevent the physiological instability due to hypovolemia and hypothermia. The other causes of polyuria, such as hyperglycemia or use of diuretic and osmotherapy, should be excluded before considering the diagnosis of diabetes insipidus. So, management of diabetes insipidus, fluid should be replaced by balanced salt solution to correct hypotension. If further correction of hypernatremia is required, once volume status is stabilized, uh, hypotonic fluid with the low sodium content should be considered with close watch for hyperglycemia. Central diabetes insipidus should be treated with desmopressin or vasopressin depending on the patient's clinical status. In donor presenting with hypotension, start intravenous AVP at a zero point zero 0.01 to zero point zero 0.04 international unit per unit. Vasopressin IV infusion at a dose of zero point 0.5 to 2 unit per hour is indicated when central diabetes insipidus occurs in association with the hypotension refractory to the fluid resuscitation. It acts equally at all three vasopressin receptor, so has the pressure effect in addition to antidiuretic action. Aim is to maintain sodium level between 135 to 145, but no more than 155 during management of central diabetes insipidus, because some study report worse liver graft survival with higher concentration. Diabetes insipidus with hypernatremia without hypotension. Desmopressin, a vasopressin analog with greater affinity for V2 receptor can be used. Dosage: an initial IV dose of desmopressin 1 to 4 microgram is used, and subsequently dose titration as per urine volume and serum sodium concentration and urine osmolality. Additional doses, that is 1 to 2 microgram per every 6 hours, may be required. Thyroid hormone deficiency. Circulating triiodothyronine may be low in patients with the brain. Thyroid hormone deficiency, along with the cortisol deficiency, may contribute to hemodynamic instability. So, the function of anterior pituitary is partially preserved with a normal level of cortisol and thyroid hormone. So, low thyroid hormone with the normal or raised thyroid stimulating hormone level consistent with the CQ thyroid syndrome. Abnormal thyroid function are seen after brain death is consistent with the CQ thyroid syndrome rather than the prohypothyroidism. So, thyroid hormone replacement may only be needed for hemodynamically unstable patient, and if cardiac function does not improve in spite of volume fluid resuscitation and vasopressin. Now, the next is corticosteroid deficiency. The presumed reason for the corticosteroid deficiency is firstly hypothalamic pituitary adrenal axis failure, which could mediate hemodynamic instability. Secondly, hemodynamic instability and hormonal imbalances in brain dead donor leads to release of pro-inflammatory and immunological mediators. This has been associated with the reduced graft function. High dose of corticosteroid may reduces the brainstem death, induce inflammation, and hence modulate immune function. This improves the donor organ quality and post-transplant graft functioning. This has also shown to improve the lung. Brain death causes the hormonal imbalance, results into the reduced insulin synthesis, increased insulin resistance, and gluconeogenesis. If untreated, hyperglycemia may cause pancreatic cell damage, which may affect the pancreatic graft. Measures should be taken to maintain the strict euglycemia to minimize the risk. Insulin infusion should be initiated to control sugars. Blood sugars must be maintained in the range of 80 to 150 mg per gram. Now, the hormonal replacement therapy. Vasopressin 1 unit bolus followed by the infusion of zero point 0.5 to 4 unit per hour. Methylprednisolone 15 mg per kg immediately after diagnosis of brain death and 24 hours thereafter. Another option is 250 mg bolus followed by the 100 mg per hour infusion till organ retrieval. Insulin infusion to maintain blood glucose between 80 to 150. Thyroid replacement therapy, it is replaced either alone or in combination of hormone therapy with corticosteroid, vasopressin, and insulin. T4 20 microgram IV bolus followed by the infusion of 10 microgram per hour, or T3 given as 4 microgram bolus followed by the infusion of 3 microgram per hour. T4 improves hemodynamics and prevent the cardiovascular collapse in hemodynamically unstable organ donor. However, intravenous T3 generally not available. So T4 oral 300 to 400 microgram every 8 hourly is suggested instead of T3. Now, the respiratory system, neurogenic pulmonary edema and inflammatory acute lung injury are two main factors causing the respiratory failure in brainstem death patient. The other contributing factors for the lung dysfunction include chest trauma, aspiration atelectasis, and nosocomial pneumonia. This causes acute respiratory distress syndrome like picture. Now, how to manage this? So, the lung protection ventilation, that is low stage protocol, should be used. Tidal volume should be between the 6 to 8 ml per kg of predicted body weight. PEEP should be 8 to 10 centimeter of water. Closed circuit for tracheal suction. Alveolar recruitment maneuver after any disconnection, and use of continuous positive airway pressure during apnea test. Respiratory target should be pH should be between 7.35 to 7.45. Partial pressure of oxygenation should be above 100 mmHg with the use of minimal FiO2. O2 saturation should be above 95. Partial pressure of carbon dioxide should be between 35 to 40 mmHg. Renal tubular injuries are caused by pro-inflammatory and procoagulant effects secondary to the brain death. Management should be appropriate fluid management and maintaining renal perfusion pressure. Fluid overload should be avoided. Oxygen saturation should be between the normal limits and the normocapnia should be maintained. Hypothermia occurs in brain death patients due to loss of thermoregulation, reduced metabolic rate, excessive heat loss, and loss of the protective mechanism such as the vasoconstriction or shivering. Exposure and the administration of the cold fluids may further increases the risk of hypothermia. Hypothermia has the direct effect on cardiac function, arrhythmia, coagulation cascade, and oxygen delivery to the tissue. Now, how to manage this hypothermia? Surface warming using warm blanket should be performed for all patients with hypothermia. Aim is to maintain temperature of over 35.8 degrees Celsius before and during retrieval operation. Active warming can be achieved using warm blanket, fluid warmer, and heated humidifier in a ventilator circuit. Administration of warm IV fluid and adjusting the ambient temperature. Anemia, coagulopathy, and immunological changes. Traumatic bleeding commonly results in anemia. Coagulopathy fluid administration may cause exacerbation of anemia. Then significant rise in pro-inflammatory cytokines such as interleukin 6 has been observed into the brain dead donor, which could be one of the cause of coagulopathy. It may be worsened due to hypothermia. It is recommended to maintain hematocrit above 30%. If HCT drops below 30%, then 2 units of PRBC should be transfused. Coagulopathy should be treated with blood products. Infection management, severe brain damage and the cerebral death predisposes to the infection due to heavy impairment of cellular immune system and hemodynamic instability with the consequent bacterial translocation from the bowel. The invasive lines used for the monitoring purpose, mechanical ventilation and inadequate nursing, medical management can increase the further chances of infection. Presence of infection may complicate the donor organ and further recipient. The actual rate of unexpected infection transmission from donor to receptor is low. occurring in less than 1 to 5% of solid organ transplant recipients. Bacteremia or sepsis are not contraindication to the donation, provided pathogen-specific antibiotics have been administered for at least 48 hours prior to procurement. Now, donor with the bacteremia or sepsis or with positive culture, is it contraindication? The incidence of positive blood culture appear to be more in older donor of that is of age of more than 50 years and in donor whose length of first stay is more than 3 days. In younger donor that is of age of less than 40 years, bacteremia is mostly due to gram positive and in older it is due to gram negative. But the rate of transmission of infection to recipient is less provided donor organ procurement is delayed for 48 hours so that donor receives the antibiotic as per culture sensitivity for 48 hours. If blood culture of donor comes positive after organ transplantation, this should be communicated with the transplant intensivist or transplant surgeon so that recipient receives pathogen specific antibiotic at least for 7 to 10 days. Can post brain dead donor with meningitis donate the brain or donate the organ? So potential organ donor with bacterial meningitis are considered suitable for organ procurement uh, only if they receive pathogen specific antibiotic or therapy against the probable pathogen. The suggested duration of therapy is same as above, that is 48 hours, and the recipient should receive similar antibiotic for 5 to 10 days. Now, the post-brain dead donor with undiagnosed febrile illness, encephalitis, meningitis, flaccid paralysis of unknown cause, or lymphocytic choriomeningitis virus, rabies are absolute contraindication for organ donation. Thank you.